So what are the issues for real-world evidence study publications, bearing in mind what we've said? The first is real-world evidence is still mistrusted. It's still considered less robust than randomized controlled trials. A couple of data from surveys. One example was a survey we did of members of ISMAP asking if they felt data from real-world evidence studies was as robust as randomized controlled trials, and the overwhelming majority said less robust or much less robust. Very, very few thought more robust. And this was a survey that another group did of actual decision makers, and it's asked for their level of comfort with observational research, so how comfortable were they with real-world evidence, but a very, very similar answer. Most were not very comfortable. So people don't trust it. Why not? There are barriers to the credibility of real-world evidence. It's the fact that you don't randomise, you don't have control over what patients get which drug. There's issue over whether the results are representative, the fact that you can do lots of different studies, and the fact that studies can contradict each other with their results. These are all issues, particularly for real-world evidence, because they're less common in randomised controlled trials. So to break those down one by one, think about lack of randomisation as an issue. This is a Jeep Cherokee. So the manufacturers of Jeep published a study where they showed this is the standing quarter-mile time Jeep, and it's faster than the Porsche. Jeep is faster than Porsche. Anyone see any problem with what's been done here?
Conditions.
Yeah, the conditions are somewhat different. You tested the Jeep on a track and you tested the Porsche in the snow. Now this is the kind of thing that happens, or it's a concern if you don't randomise. You've not randomised other potential confounding characteristics. You've not made sure they're matched for things like the conditions. In a clinical trial you try and match the patient characteristics to some extent by randomising. And so you get a result that's confounded. This has nothing to do with the cars really, it's the conditions they're found in. And if you were to remove that confounder and do these two both in the same conditions and both cars on the track, of course the Porsche would end up faster. But this is the concern over real-world evidence. If you can't randomise patients, how do you know any differences you're seeing are anything to do with the drugs and they're not just some bias? There are actually ways you can make up for the lack of randomisation by trying to come up with matched groups, particularly if you're looking at comparative effectiveness. One is propensity score matching, and it basically tries to find patients that are overlapping in characteristics. If you accept that one drug will be given to a different population to a second drug, you try and find patients that are similar in between. There are ways you can do this, there are other ways you can adjust for the baseline characteristic, all sorts of models. But the key thing in terms of publications, real-world evidence, is you need to say what you've done to eliminate bias. And you need to give some comfort to the reader, to the audience, that you minimise the confounding. So that's the first barrier that's there. The second is the representativeness of the results. So here's, again, Jeep Cherokee in the snow, and here's the Porsche in the snow, and the Jeep's faster. Now this looks much fairer. I can't see an obvious problem with this. But the challenge if this were real-world evidence, let's say this was a study of one drug versus another in a particular patient group in France. You might ask, if you're in America, well, is this representative of the patient population that I'm seeing? So here you might ask, well, is this representative of the conditions in which you'd normally use Porsche? The answer is no. And the representativeness is an issue for the real-world evidence because of the data source. When you do a real-world study, there's lots of data sources you can choose from to do your study, and there's different sorts, and they give different information, claims databases, there's registries, there's electronic health records, and they all give different things. And when you're doing one of these studies, you choose what data source you do your research in. So how do you know that you've chosen the most appropriate data source? The only way really to do that is to give some sense to the reader that you've performed some due diligence and you've looked at all of the available data sources and picked ones that are appropriate for your analysis that would give the most appropriate result. Now what's very convenient is Oxford PharmaGenesis created something called HEOR assessments, which is a systematic understanding of real-world evidence. And this is a process whereby we look systematically at the potential sources of evidence you could use for a real-world study, identify the criteria that address the research question you want to answer, and evaluate the sources and actually say, well, this source is appropriate for these reasons, this source is not appropriate for these reasons. Perhaps has the wrong patients in, doesn't follow them up for long enough, there are too many gaps, it doesn't look at the right outcomes. There are lots of potential reasons. But it's important to do this, and it's important to publish it, and we have published these. There's a poster we presented this for, and there's also been papers that have come out now. But this is actually really important because it gives credibility to your study if you've gone to the right data source. Because the suspicion otherwise is that you either just went to the cheapest or the most readily available, or the one that gave the best result. And that's not what you should be doing in good science. And that leads on to the multiplicity of studies issue. Here's a trial by a manufacturer, Porsche, a study they published showing Porsche is faster than Jeep Cherokee. The suspicion over real-world evidence comes from the fact that you can do real-world studies, if you do a database analysis, you can do them relatively quickly and relatively cheaply. Randomized controlled trials are not cheap and they're not quick. So there's the suspicion that if you publish this, let's say it's a database study of 2 drugs, but if you publish this study showing Porsche is better, how do you know that that company didn't do a whole load of other studies in different databases, different characteristics, where Porsche didn't win, but they just didn't tell you about those. They only published this one where they did win. That's a real concern because I presented this a couple of years ago at a meeting and someone from a pharma company got up and said, you're absolutely right. When did you ever see a pharma company lose its own HEOR study? You don't. And that's a suspicion that it's publication bias. You only see the positive ones come through. I mean, what can you do about that? It's not actually very easy, but you need policies for real-world evidence that are as robust as the ones that were brought in for randomized controlled trials, because the suspicion used to exist for randomized controlled trials as well, that we were only ever seeing the ones that gave the positive results. The ones that weren't, they just weren't published. And it's about policies, it's about posting the protocols, telling people that you're doing this real-world evidence study, saying that you're going to commit to the publication of the study. Those are very important things that can be done, and some companies are doing this now for real-world evidence. And the policies can go into different things as well. You can think, what is an RWE study? What's the definition that we're covering? How do you define authorship? Who accesses the study data? The commitment to publication? And compliance with publication. So there's a lot of things you can do from a policy level that borrow from what's been done with randomized controlled trials. Final issue to address is the contradiction of studies. The manufacturer Porsche does this study showing that under these conditions Porsche is faster than Jeep. The manufacturer Jeep does the study showing that in different conditions Jeep is faster than Cherokee. Faster than Porsche. What do you do if you're a physician and you're confronted by one study showing drug A is better than drug B for a particular outcome, and a different study shows drug B is better than drug A? You probably don't have the expertise to evaluate the studies in a lot of detail. So it's then very hard to understand what you're seeing here. It's also hard to do meta-analyses of real-world studies. So what do you actually do? It's difficult, but from the perspective of a publications professional, the best thing you can do is to be very clear about what your study has done. Be transparent about the methodology so that people can look at it, and if it's written well, we'll say, okay, I can see they've taken appropriate steps to minimise bias, they've chosen an appropriate data source, and the analysis steps are reasonable. And the best way to do that is to follow the guidance. The STROBE statement is very good guidance on writing up epidemiological studies. Similar things exist. We talk about HEOR and patient-reported outcomes, but follow them, because they are ways to help you write a paper that demonstrates to the reader that you've done a robust study that's to be believed. And if you can do that, and a conflicting study isn't clear, then you're exposing a weaker study for what it is. Following the guidelines is very important. And the fundamentals for real-world evidence is, for the best impact and value, you should plan, perform and publish real-world evidence as you would randomized controlled trials.